Good afternoon, everyone. Nice to see you all with us this evening. My name is Irit. I'm the VP of Marketing at AB Dental. We are very happy to have you with us. Tonight, we are going to present our new innovative research done by Professor Tzvi Schwartz, Dr. Gustavo Yatzkaier, which is one of our most important KOLs at Israel, is going to present the research. Now I'm very happy to invite Dr. Gustavo Yatzkaier to show you the research results. Thank you, Gustavo.
Okay, hope that you are hearing me now. As Irit told you, I'm an oral maxillofacial surgeon that I'm doing implantology for more than 35 years. It's an honor and a pleasure for me to be here with you, dear colleagues and distributors. And the presentation for today will be the role of hydrophilic surface on implant osseointegration. Before I start, I want to disclose that I'm medical advisor for AB Dental Devices, and this presentation will be in behalf of the group of Professor Tzvi Schwartz from the Department of Biomedical Engineering in the Virginia Commonwealth University in USA, and in collaboration with AB Dental. We are working with implants a lot of time, and we know that the titanium was chosen as a material because part of its properties, such as bioinertness, biocompatibility, and mechanical stiffness. But the problem with the pure titanium was the titanium pure did not connect with the living bone. In order to overcome this problem, the manufacturers start to increase the surface area, meaning to do some small or smooth roughness in order to permit the binding with the bone and enhance the firmness and stability. As we talked before, the manufacturers did very efforts in order to increase the surface area of the titanium and to permit this binding to the living bone. The first implant we call the machine implants, and were created by milling, turning, or polishing techniques. But two problems we found with these implants. The first problem was that the healing time was longer, from 3 or 6 months to 9 months. And the second problem was a high rate of early failure. Today we have 3 groups depend on the roughness. As we talk, the machine group, the roughness averages from 0.3 to 1 micron. The second group is the moderate, that is from 1 to 2 microns, and the rough is more than 2 microns. There is not consensus in the literature which is better. At this time, it's important to know that when we do implants, we are talking about osseointegrations. But in fact, there are 2 different processes that are running together. The first process we call the primary implant stability. Is totally physical. When we insert the implant, we must have skills, very good skills in order to do this drill, but also the implant design and the geometric are very important to this process succeed. The second process is the osseointegration. The osseointegration will run together with the primary stability, and it's more complex process that the final result will this intimate contact between the titanium and the bone of our patients, and avoiding micro movements to avoid fibrous integration. We can see here in this picture a research that was done in vertebrae of sheep. We can see here clearly the osseointegration achieved. In the right side, we can see in blue the fibrous integration. The same thing in humans. In the left part, the correct or the good osseointegration, and in the right part, the poor osseointegration. To make it simple, the osseointegration have 4 stages. The first stage, that is the homeostasis, is taking minutes. When we drill the bone and cut also on the bone and the blood vessels, we have a bleeding. With this bleeding, in the bloodstream are going out some substances like cytokines, proteins, markers, signaling. Also, the platelets start to aggregate each other in order to form the blood clot. This blood clot will be the network for the wound healing. Between some of the substances that are going out, we have the bradykinins. The bradykinins increase the permeability of the blood vessels and permit that polymorphonuclear leukocytes will go out and go into the second stage that we call the inflammation. In the inflammation state, also the polymorphonuclear leukocytes in the first wave and the macrophages in the second wave, they start to phagocyte and to eliminate all the debris, the bone chips, and the bacteria. If this process will succeed, the osseointegration will continue. But if not, we will see here a failure, an infection failure, meaning that our patient will come swollen with pains, a lot of pains, suppuration, the implant is mobile, and if we do a radiograph, we see a very fast bone destruction. This stage will take some hours. Afterwards, we go to the third stage, the proliferation. At this stage, the mesenchymal cells will differentiate. It can, depending the signaling, can differentiate in fibroblasts. Those fibroblasts will secrete collagen that is also important for the angiogenesis and the wound healing. And some perivascular cells will transformate in osteoblasts, osteocytes, and osteoclasts. Those osteoblasts will start in the third stage at the final, at 1 week approximately, to secrete the bone marrow, the woven bone. That is the first bone that will be secreted. This bone will lay down parallel to the surface of the implant, and after 1 week, it will be resorbed by the osteoclast. And now we will go to the final part, that this is the second bone remodelation. At this time, the osteoblast conducted by the osteocytes will secrete the lamellar bone. This lamellar bone will be very important in order to improve the success of the implant and the survival rate, and it will take years. There are a myriad of things that can decide if we are going to the osseointegration or to the fiber integration. Those things are implant design, the surface, the composition, the topography, the energy, the roughness, but also our skills and the patient situation, the host immune response. Most of the implants that we are working with today are with a high success rate and survival rate at 10 years, more than 90%. Those are hydrophobic surfaces, meaning liquid repellent. Those surfaces are working excellent in healthy patients, in good quality of bone, or when we work slowly. In order to improve the surfaces, the manufacturers are working with some techniques. Some of them are chemical, like acid etching, can be also physical, like grid blasted, or also they can use heat-treated surfaces. To make it simple, we have 3 classes principally. Some of them are working physically in the surface, such as the machine surface, the laser etching, the sandblasting. Some of them are chemical, such as etching, acid etching, alkaline, anodization, or some are biomimetic surfaces with coatings, peptides, or antibiotics. As I talked before, most of the surfaces are hydrophobic, and the goal today, in order to improve those surfaces, is to change the charge, meaning to do a process that we call functionalization. We try to change the free charge of the surface in positive. We know that the proteins that have it bound are negative, and those different poles will be attracted each other. This will be the goal to shift those surfaces from hydrophobic to hydrophilic. Why these surfaces are hydrophobic is because when we open the package, before we insert the implant, the hydrocarbons of the air will adhere in the surface, at least 60% of them. And these hydrocarbons will decline the bioactivity over time. This change to hydrophilicity will improve the cell adhesion, the differentiation, the proliferation, such as also the bone mineralization. But the literature shows us that the most improving of the osseointegration will occur the first weeks, from the second week approximately to the 6th week. And we see an improving in a BIC, the bone implant contact. We know that the bone implant contact, we can measure it by percent. We cannot achieve 100%. We can achieve from 30 to 80% approximately, but it depends on the quality of the bone, meaning that if we have a lamellar bone, we can achieve that at least or up to 90%, but if we have a medular bone, we only can achieve 50% of this BIC. But our bones are a mix. We know this. We have 4 types, and the type 1 is most lamellar. We can achieve up to 80% of BIC. In type 2, up to 70%. In type 3, up to 50%. And in type 4, up to 25% of BIC. In order to change or to shift this surface from hydrophobic or hydrophilic, the companies are using some techniques. Some companies are doing this in the factory using nitrogen or using salts. And other companies have tried to do this in devices that you will or you can use in the clinic. When we want to see devices that we can use in our clinic, there are some techniques, some different techniques. We can change this surface using plasma, argon plasma, or ultraviolet radiation. But what is plasma? Plasma is a high electrically charged gas. Plasma we have in the universe. The sun is plasma, the stars are plasma, the night light are plasma, and this plasma influence in the implant and change the charge of this surface. The manufacturers start to use cold plasma, less than 40 degrees. The temperature is easier to use and to produce those devices. Also, they can use or vacuum or atmospheric pressure plasma. There are several methods for generating this plasma or this change. One of them is the DBD, meaning the dielectric barrier discharge plasma. But there are also another, such as a plasma jet or gliding arc discharge. The goal of this change is to improve the wettability, okay, and the adhesion of the proteins without changing the topography and chemistry of the implant. And all of them, of course, to improve the osseointegration. The manufacturers need to measure in order to see if this surface was changed. how they do this? First, they take a drop, a sessile drop, and they put the drop in the titanium, and they measure the angle that was achieved. If this angle is more than 90 degrees, we are talking about hydrophobic surface. If it's less, it's preferable to be less than 30 degrees. We are talking an hydrophilic surface. If this surface will be 0 or less than 10, we are talking about super hydrophilic surfaces. And of course, the goal is to reduce the hydrocarbons and to improve the osseointegration without changing the microtopography. It's well known in the literature that this changing work in the osseointegration. We can see here one factory that changed it, and we can see a high reduce in carbons. They call to the surface the modified SLA, okay, and then they reduce this carbon. The problem is that we know today that this property, the hydrophilicity, can decrease or disappear with time. And we need to take into account the factories or the companies produce the implant. Some of them put the implant in saline in order to preserve this property. Some of them that are working with salt, it's not necessary, the implant can dry, but you need to take into account that the factory produced the implant is sent to the distributor put the implant in the shelf, afterwards they send to the clinic, and we put the implant in our shelves in the clinic, and we don't know what will happen with this property. The goal is to change this surface in our clinic in order to avoid this decrease in the property. As we can see here, the manufacturers put a drop in the left side. We can see a drop that is totally hydrophobic with 138 degrees. And in the right side, we cannot see the drop because it's totally hydrophilic, 0 degrees. And this is our goal. Another important thing is not to change the topography. And now, most of you, like me, we are clinicians. We need to know how to read a graph, and in order to see not only this change in hydrophilicity, also to see if the osseointegration was improved. What we need to see? In the upper left part, we can see the cell number. When the osseointegration is improved, we need to see a decreasing in the cell number. In the right part, upper part, we can see a bone marker like osteocalcin. We have a lot of them: osteocalcin, osteopontin, osteoprotegin, BMPs, and also growth factors. As we can see in the graph, in the lower graph, we need to see that is growing, as we can see in the modified SLA surface. Now I want to share with you a work of the group of Professor Schwartz. They work in a disc with titanium, and they work in 3 groups. The PT group is a pre-treatment surface. They did a very small rough surface. They work also with SLA and modified SLA. They work in rats. How can we compare, or the researchers, between rats and humans? When the rats have 2 months old, we are talking about healthy men. And when we see a rat of 9 years old, we are talking about compromised healthy men. We can see here in this graph that all the surfaces using in healthy men or young rats are the osseointegration was achieved in all the surfaces. But in the 9-month rat, we can see that only the modified SLA achieved the osseointegration. In those graphs, we can see that also the marrow bone implant contract was achieved mostly in SLA and modified SLA when we talk about young rats, that is in black. But the differences we can see in the black signal that in the gray signal, when we talk about 9-month rats. Also in the marrow blood vessel number, that in the modified SLA growth was increased that with the comparison with the other surfaces. At this time, it's important, or I want to share my own experience with my failures. I saw that my failures occurs more in compromised patients, compromised areas, or when I stretch my boundaries. And this will the goal to use hydrophilicity surfaces. The group of Professor Schwartz did this research in order to examine 3 different benchtop devices and to see if those surfaces are changed from hydrophobic to hydrophilic, but not only. The second goal was to check this transformation improve the osseointegration. The first device that I want to present was the dielectric barrier discharge plasma. As we talked before, we need to measure the drop. This is the device that we can use in our clinic, but this device, the implant came in a glass container with a vacuum environment. This device using the technology of dielectric barrier discharge plasma, meaning that the plasma activate the implant, producing this change. The group divide the work in 3 groups. The first group was the grid blast surface. The second group was grid blasted and acid edge surfaces. And the third group, the same with plasma activation. Here we have 4 graphs in order to show you that there was no or was a minimal changing in microtopography. That is very important. Here we can see that in group 1, drop is totally hydrophobic, more than 90 degrees. The second group was still hydrophobic, but the third group we can see a totally shallow drop, meaning an hydrophilic surface was achieved. Chemically and biological, we can see in the graph A that this cellular proliferation decrease is very good. We can see also that osteocalcin, osteopontin, osteoprotein, and the BMPs increase, and also the vascular endothelial growth factor also increase. This meaning that the osseointegration was improved. Afterwards, the group goes to the in vivo work, working with rabbits, New Zealand rabbits, 50 females, 90 males. They work in 2 cohorts. The cohort 1, they do mechanical testing, and in the cohort 2, they do micro-CT and calcify histology. At this time, it's important to say that in the first work, they work with disc, the titanium disc. At this time, they work with rods that were prepared by AB Dental with the same surface that we are working today, meaning RBM. This is a resorbable blast media that blasting with biological calcium phosphate. And in order to achieve this roughness, afterwards, they use a hot and thermal working with acid etching in order to achieve the roughness and the microstructure that the company wants to achieve. Here we can see the work of the group in the micro-CT. We can see in the graph, in the upper graph, that the BIC was increased or was better in males, that in females, also in females increased, but less than in males. Also the ages bone volume growth in males more than in females, compared with the control, of course. Here we can see the isomorphogenetic preparates, and also we can see that the bone to implant contact was better in males, in a marrow or in a total, and that when we compare with females. But in females, we saw an increasing in torsional stiffness, meaning mechanical properties were better in females than in males. Chemically, we can see, as we see before, that the cellular content decrease, the alkaline phosphatase increase, also the osteocalcin, the BMP is more immense in males than in females. In conclusion, this bench-on plasma can alter the wettability of the implant surface, but without modification of the topography. This is very important. Second, this plasma activity enhance the differentiation and the activity the mesenchymal cells and the osteoblast in vitro, but also preclinical, also in vivo, we saw an improved mechanical stability after 6 weeks and increasing in bone implant contact, also in micro-CT and in histomorphometrics in males, and improved torsional stiffness in females. The researchers thought that this difference was because the osteoblasts of the males were more sensitive to those changes. In summary, this device did the work, meaning change the surface from hydrophobic to hydrophilic and improve the osseointegration, stimulating the mesenchymal and osteoblast differentiation. The problem with this device was that this glass thing was very expensive, and the companies prefer to use another device. The second device that was checked by the group was the low UV radiation. The same thing, the goal was to see the changing from hydrophobic to hydrophilic and to see if there is an improving in the osseointegration. Here we can see that the drop was less than 10 degrees, very hydrophilic surface. As we can see in the upper right part, the drop is totally shallow, but the problem that we can see here that in some markers as the osteoprotein decrease, not increase. The cellular proliferation decrease, some osteomarkers increase like osteocalcin, the osteopostin, but the osteoprotein decrease. In a summary, this low UV radiation induced hydrophilicity, but had no effect in mesenchymal differentiation and factor production. The third device that I want to present now is the DBD with the vacuum. The same thing the group checked. We can see in the upper part in the right that the drop was totally hydrophilic, less than, I think, 2 or 3 degrees, very super hydrophilic surface. Chemically and biologically, we can see a decreasing in the cellular proliferation. We can be an increasing in the osteomarkers like the osteocalcin, osteopontin, the osteoprotein. The factors, it's a little decrease, but not significant. The group did another check. I need to, okay, one moment, double check. I don't know if our videos will work. Is working? I think not. No. Okay. Okay, I will. Can you help me, please, to put the next? Oh, okay. A moment. It's working slowly, but working. Okay. Afterwards, the team will show you the videos. Are the same video. You can be totally quiet. Okay. In summary, this device that we are presenting today and the team will show you induce hydrophilicity, okay, stimulate the mesenchymal cells. In other words, improve the osseointegration. What is the clinical significance? First of all, we have a device and we can put in and use it in our clinic to change the property in the same time. And we cannot be worried about the decreasing on the property, on the hydrophilicity. The second thing, very important, is that we can improve our success rate in compromised patients, compromised areas, or when we want to stretch the boundaries. Third, we can use in other implants with rough surface. I talked with the manufacturers. This device was working also in SLA surfaces, but in zirconia. But it's very important to say now that improving on the osseointegration was checked only in a dental implant surface. This was the group done. And of course, if you can use the device, and you can wait 48 hours after the activation. In other words, the question is, if I want to do, say, for example, 10 implants, it's not necessary to activate each implant inserted. We can activate all the implants. We can wait until we insert into the mouth. The indications, I want to share with you my indications, okay? There is not totally clear, and I want to share with you when I'm using the device. First of all, it's important to say that we can use the device in all our implants. We can use in all of the cases. But I try to saw my failures and to use first in those failures, meaning in compromised patients like unbalanced diabetes or immunosuppression, a poor bone quality like type 1 or type 4, implantation with bone grafting and the same procedure, or implant failures. I want to share with you 4 simple cases in order to show you what I'm doing only. The first case is a 33-year-old man, very young man, with a psychiatric treatment in a 35 area. But the interesting thing was that the quality of the bone was a type 4 bone quality. As we can see here in the CT scan, very soft bone. I inserted the implant, and I want to tell to you that this implant was rehabilitated. The second case is about a 42-year-old man, healthy, with an implant in the 36th position. In this case, the bone was the type 1. The problem was that I inserted the implant, and I saw a very fast bone resorption, a cervical bone resorption. In this case, no play. I removed the implant immediately. I wait for 3 months. we can see here the CT scan. We have in the CT scan previous to the implantation 7.5 millimeters. But today I'm working in my clinic with the CT scan. I'm doing the drill, a safety drill. I insert a parallel pin, and with this technique, I can achieve a length of 10 millimeters. That is correct. The third case, we're talking about the 65-year-old man, also healthy, but I insert the implant with a closed sinus augmentation, a very small amount of pristine bone of our patient. We can see here that I did 2 closed sinus augmentations. As we can see here in the periapical radiograph, the implant in place. And the last case is about a woman of 63-year-old, healthy. I did multiple extraction and insertion that we can see here of 10 implants. The 16 implants failed. I removed it, and I inserted with the plasma activation after 3 months, as we can see here. In conclusion, my friends, first of all, the DVD plasma that was the last device that I presented changed the hydrophobic in super hydrophilic surface with minimal change in the surface topography. The osteogenic markers were increased. As we talked before, the cellular proliferation decreased, indicated that the osteoblast differentiation and the osseointegration was very good. We need to know that not all most of the devices change the surface from hydrophobic to hydrophilic, but not all the devices improve the osseointegration. This is very important to know. Is because that it was very important, the research of Professor Schwartz, in order to see this improving in the osseointegration. This biofunctionalization, I want to present a work of Paolo Pesci from Italy. Also, this group found that the plasma functionalization improved the osseointegration. And this work done by Myron Davis from USA, they did a work in beagle dogs, not in rabbits, and they found not also an improving in the osseointegration, also in reducing a vertical or cervical bone loss. They also suggest that we can shorten the healing time, meaning to do the rehabilitation before as we did until our days. But in order to finalize my presentation, I want to say that more research is necessary in humans, and we are doing. And when we found those conclusions, I will be very happy to present to you. And I want to thank you for hearing me, for coming, and also for AB Dental for invite me, and the group of Professor Zvika Schwartz for this very nice research. Thank you very much.